Welcome from Eric and I. This course is called Functional Stability Training of the Core. Fancy word or phrase, whatever you want to call it. I think we have a lot of fancy phrases out there nowadays, especially with the onset of the internet age, where everybody can make up a system and package it together on the internet. For me, I think we chose to use that phrase functional stability for a reason, though, and we'll talk about that all morning and what that means to me. But I think what it does is when we call this functional stability training instead of functional training or performance training, I think it reminds us of a very important dynamic that sometimes we miss. So again, thank you guys. This is the website that, obviously right now is just for this seminar, but we're going to build it, but functionalstability.com. So Eric and I will have whatever we have for our educational opportunity down the road, whether it be a DVD, an online component, both, who knows, we'll have on this website. And I fully intend, and hopefully Eric will join me, I'm putting him on the spot because we didn't talk about this, but I kind of fully intend to build this a little bit more and include upper extremity, lower extremity, maybe even some manual techniques, mobility techniques. So really want to grow this thought process, because in a nutshell, and we put this on the website, but what is functional stability training? It's how I approach rehab, and I know it's how Eric approaches his training programs. So it's a different thought process. It's not just simple exercises, but putting it all together and really talking about human anatomy and how we function. So again, this morning, it's going to be a lot of lecture. It's going to be the stuff that we'll struggle to get through, but the lecture material is going to really set really the whole day up, and it's going to help lab. We're going to show a bunch of video techniques. We're going to talk about a lot of our principles and our philosophies of why we do what we do. And then more importantly, this afternoon when we get to the lab, you guys are going to get in there and actually perform some of this stuff. So it's not rocket science. And everything we're talking about today is not going to be rocket science, but what it is going to be talking about how you package it all together and how you think of it together as a system versus just doing some low back rehab or just doing some exercises and strength programs for somebody that may or may have had low back issues in the past. So the first thing we'll talk about is just functional stability training itself and what that means to us. Again, fancy term, FST, whatever you want to call it, just to keep it simple, fancy, just way of saying this is how we treat. This is how Eric and I treat. And this is how I approach kind of how I build rehab and performance programs for everybody that I may come across. So what is it really? Well, it's a comprehensive approach, meaning it takes principles from every discipline. So physical therapy, athletic training, orthopedic surgery, functional anatomy, biomechanics, strength and conditioning, performance enhancement, puts it all together into one thought process that we can all benefit from. So obviously we all have scopes of our practice. We're all not going to be, doing the same aspects of it, but understanding the whole system and how it integrates into your scope of the practice is pretty valuable. So you'll see that. So traditional programs, I think, miss a big boat on stability. Stability is challenging. Stability is truly how the body functions, and probably one of the most important concepts of how we move, perform exercises, perform functional activities, perform sport activities. It's all from stability. Okay, and we'll talk about that as the morning goes on, but it's probably the most often overlooked component of our programs as well. So that's really going to be kind of the basis behind what we're talking about. And it's not just a simple term, stability, but it's a real dynamic process that involves really how the body's supposed to function. So functional anatomy, functional biomechanics, and how do we train that so that way it carries forward for our injured and our healthy people as well. So obviously the emphasis of this is to train the body to replicate their functional motions. That's what's going to happen over time. That's the important part. This whole concept of functional stability training works in tandem with manual therapy, obviously. You can't just have an exercise component where we just talk about doing specific exercises without talking about mobility, myofascial work, even if it's self-myofascial work, as well as manual therapy in terms of a skilled clinician's hands as well. But it's about restoring posture, muscle imbalances, deficits within the body. That's the whole secondary component of that. What we're going to talk about is more of just the exercise component today. So the components really of functional stability training: motor control re-education, excuse me, dynamic stability, isolated strengthening, reactive neuromuscular control, and then of course endurance training. And this is interesting, isolated strengthening I think is an interesting, one here. I think if you ask people opinions on what they want to do, how should we build our programs, what it may be, you either have people where, get real strong and everything will carry over, or just be real functional and don't worry about it. We'll see that in ACL rehab. For some reason, if you look at the literature right now of ACL rehab, there's a ton of studies that are coming out now that compare traditional rehab, so we'll call that regaining your mobility and getting your strength back, versus functional rehab, which is balance, neuromuscular control, perturbations, etc. And they compare those two, and they always find that they're both effective in their own ways. So the traditional group was really good at getting their strength, and the functional group was really good at making the patient happy. So their satisfaction, their overall outcome was good. They returned to activities, they were happy, they were satisfied. But I don't see why we need to pick one, right? Like, why just pick the traditional and the functional? We need to have a blend. And that's an important concept to me. So there's a lot of people that knock isolated strengthening. We're going to talk about a bunch of different models in the body, but for the shoulder, for example, they just, they'll knock rotator cuff strengthening. Why? Well, I don't know if that's something we should do, and that's what we'll talk about over the course of the day today, is why we still need to do that. But the real goal for me is to understand what's the true role of how our muscles function in the body, the true role. Okay, so if you go back to college and maybe even high school, if you took an anatomy class in high school, and you talk about what we learned for anatomy, it was very origin, insertion, action, type of learning for anatomy, right? But it wasn't putting it all together. It wasn't talking about what the true functions of the muscles are. So this is the most important concept to me in terms of educating the system, is talking about what's the true role of our muscles. Okay, so do our muscles move our body? Yes, but they also stabilize our body. And that's what we're going to focus on here. It's not just what a muscle does to move your arm, to move your leg, but how does it stabilize it during functional activities. That's more important for me. So joints, when we look at the human body, because obviously the body's made up of a bunch of joints, they're stabilized through both static and dynamic stabilizers. Those are the two ways of thinking of it, right? So if we look at both static and dynamic stability, this is how the body doesn't just collapse, right? How our bones just don't fall down into a big pile on the ground right now. It's through a combination of this stability. Every person, every joint, everything has different amounts of static and dynamic stability. Your shoulder and your knee are different. I'd say everybody in here is different. Some of you have great static stability and poor dynamic stability. Some of them are vice versa, maybe somewhere in the middle. When we look at just pure static stability, we're talking about the osseous configuration. So what does that mean? The bones, the joints, how they all work together. We'll use the shoulder as a model for this example now, but the glenohumeral joint and your scapulothoracic joint, basically your osseous configuration. That's the first amount of static stability. It's just your body's just normal joints and how they sit together themselves. The second layer of that then is in the capsules and the ligaments. Okay, so now what holds those joints together? These are two forms of static stability because obviously it's not muscle-based, you can't control it, you can't contract it, they are what they are. So you can see in a wide variety of people using the shoulder as a model, you have some real tight people, right? Maybe some bulkier people, heavier kind of muscle tone that are real tight, real rigid in terms of their soft tissue, their capsule mobility. That versus, let's say, a high school cheerleader, for example. So a younger person that is, probably a little more flexible. That's why they're doing cheerleading, right? I couldn't be a cheerleader. I just don't have the hamstring flexibility. Or the desire, but that's a whole nother conversation. But so capsules and ligaments, that's static stability. So have you ever worked with somebody that's like crazy loose, to get real scientific on you with that terminology, that crazy loosey-goose kind of person, the congenital lax person, that person struggles with static stability. And I bet more people than you give credit to that you work with struggle with static stability. So what do those people need to work in an optimal environment? They need pristine dynamic stability. Okay, so that person, they're going to have to use it even more, right? So we'll continue to talk about that. What's dynamic stability? Well, it's a combination of muscle function now. And we'll talk about this in a little bit more detail, but the difference between static and dynamic stability. Dynamic stability now is how your muscles interact and your neuromuscular control system interact to provide stability of your joints, to align your joints, to keep them moving with optimal osteokinematics, right? Okay? So that's a little bit about the difference there. When we talk about motor control, which is just basically you saying quadricep, contract. Proprioception, which is you understanding where your joint is in space, saying, okay, my knee is flexed and I need to extend it right now. Dynamic stabilization, so your muscle's ability to contract and stabilize a joint. And then finally, neuromuscular control is putting it all together, is now a quick, sudden action, and you have to stabilize so that way your body doesn't collapse, you don't put yourself in a disadvantageous position, or you don't injure yourself. Together, what's this? This is functional stability. So see how that's where this phrase came from, functional stability training was, it's not just dynamic stabilization, but it's everything. It's motor control. It's learning how to fire your transverse abdominis. It's learning how to fire your posterior cuff or your VMO or whatever it may be. This is functional stability to me. It's putting it all together. Okay? And the important part is that for us, is that we train the body to do this themselves. Right? So this is your body's ability to learn this, not using some exterior force, whatever it may be, like some of those crazy power balance bracelets that they have nowadays, right? So this would be better with audio, but you'll get it though. But it's training your body, not relying on the bracelet for your stability.
I haven't felt this dumb since I shelled out $30 for that bracelet. It's supposed to give me better balance. Try to push my arm down.
Okay.
Go ahead, you can't do it. You can't do it.
Honey, I'm home. Hey, why is your dad's car here?
It's a good show. All right. Now, when we talk about different parts of the body, let's use the knee and the shoulder as a model. I think this is a good example. Which one has more static stability? The knee, right? Right? Which one has less? The shoulder, right? Why? Well, because their osseous configuration, their capsules, their ligaments, the way that joint is structured is not a stable environment. What's your knee do? I mean, we're definitely oversimplifying this. This isn't a biomechanical course. It goes back and forth, right? Does it do a lot more? Yes, I know that. Don't write up in the reviews that Eric and I don't consider planes outside the sagittal plane. But that's what your knee does. What does your shoulder do? Everything, right? So which one's more likely to get injured? The one with less static stability. Which one requires the most amount of dynamic stability? The one with less static stability. Now that doesn't mean the knee doesn't, but it's different, the way it works. So every joint's a little different. When we talk about your core, we talk about your spine, the way dynamic stability is achieved is also completely different from both of these joints. And that's what we'll talk about this afternoon. So really when we look at different joints, we just have to realize that there's different amounts of stability. This is really the shoulder. You know, the golf ball and a tee, but this is your humeral head and this is your glenoid fossa. It's really not, you know how a lot of people do this and say like, well, here's your shoulder joint, you know, maybe you're trying to teach people that. It's not like that. It's not Pac-Man eating one of those little balls. It's a golf ball on a tee. So this is real easy to fall off. So that's the shoulder. That's when we talk about dynamic stability. This is a very easy concept to understand with the shoulder, so we'll see how this applies to the rest of the body. But so again, I'll go back. What is the true function of the rotator cuff now? So this is funny. Back in the day, I used to ask this question, like 10 years ago, something. I'd ask this question, and you know, everybody would be blank stares and stuff like that. But now, I've preached this one thing for forever now. What's the true function of the cuff? So. What's the true function of the cuff? Nice. I heard a bunch of different ways of saying it, right? Dynamic stability. Maintaining the humeral head centered within the glenoid fossa, if we want to be completely scientific with it. To dumb it down a little bit, keeping the ball and the socket together. That's the true function of the cuff. Does it externally rotate the shoulder? Absolutely. Do we need to do isolated strengthening to get the posterior cuff strong? Absolutely. But that's not the true function of the cuff. The true function of the cuff is to stabilize the joint. So we're talking about the role, you know, really what does it really do in the function. This is kind of two different concepts. So it's really about balancing these net forces, balancing anterior, posterior forces, superior, inferior forces, and 360 degrees in between. When we talk about our programs now, what are we really, really good at? We're good at strengthening what's weak and mobilizing what's tight, whether it be soft tissue, joints, capsules, whatever it may be, right? I know in my PT education, and I think there's some alumni here from my university as well, this was a good chunk of what we learned. And this is a big thing. For the PT world, this is the first thing that I try to get young clinicians and students to think differently about. It's not just about strengthening and mobility or strengthening and stretching, whatever it may be. It's about stability, right? How do you keep this person stable? Okay? Now, stability, again, it's not just about keeping the ball in the socket together or keeping your joints together. Stability is a broader term that I kind of want to, redefine maybe this weekend a little bit. But it's not just preventing a dislocation. That's a dislocated shoulder, by the way. Obviously, he's sitting outside of the joint, which is why he has that large, well, I guess it's a sulcus sign, technically. Pretty gross, but he needs stability, right? He needs stability for various reasons. Well, what about this guy? Typical human, though, what are we doing now? We're in this posture. Everybody here is in this posture. Usually when we show these slides, everybody kind of sits up a little bit, but nobody did. That's good. We're getting even more lazy. That's amazing. That's great. But real typical human, other than the fact we're often not naked sitting at the computer, but very typical posture that we have, right? Well, I guess we have a lot of people working from home nowadays, right? So maybe Tony doing his blog entry for the week right here. He looks pretty jacked. This is stability. It's not just keeping the ball in the socket together, but look at his back. Look at his joints. Look at his scapula. Look at his glenohumeral joint. That's stability. What is he doing? He's letting go of all his motor control, letting go of his dynamic stability, and just resting on his static stability to stay together. So he's that real loose guy maybe, and he's just resting at his end range of motion, allowing his static stability to be 100% in control of how his alignment is. Why? Because, well, it's tiring to sit up, right? Because we don't have the right motor control patterns, we don't have the right strength, we don't have the right endurance of different muscle groups. But this is the stability I'm talking about. Okay, so it's not just keeping joints together, but it's being able to use their muscles to align those joints. So optimal stability, maybe? I don't know. That's an interesting question, but don't forget that this is also stability. And this is what we're talking about now, because this person is going to run into a lot of problems, right? How many diagnoses do you think we can come up with this guy? He's got, let's see, cervicogenic headaches, right? Because his neck's all, crazy with upper cervical hyperextension and lower cervical flexion, right? So he's got cervicogenic headaches. He's probably got a disc bulge going at some point. So his right arm's numb. We'll just say this poor guy. He's still trying to type, but he's not. He's like a foot away from the keyboard. So his scapula's winging, right? His shoulders, he's slouched, he's forward, he's kyphotic, so he's got shoulder impingement. He's probably wearing down on his cuff. That thing's torn. Let's just say it's torn. So he's torn now. He's got headaches, his hand's numb, his cuff's torn, his back's killing him. His leg's numb right now. It's the same side too, so that's awkward. So his arm's numb, his leg's numb. When he gets up in the morning, it's crazy. That's this person, right? So next time a guy comes to you and says, I feel like I'm having some discogenic pain, maybe, I feel some radiating numbness in here. Well, yeah, I bet you are. You should be. That's kind of how you're predisposing yourself. So that's how, think about stability. What do we do? And we'll talk about this a touch just in this course, but it's not a lot. But my big thought on how do you train this person, it's very simple. Everybody likes to work in sports, right? So everybody likes to work in performance training. You want to train a baseball player to swing a bat better. You want to train a football player to run faster, right? Well, how do you train this person? Okay, if they're shoulder sore and they come to you in a PT clinic, what do? You do ultrasound, you do ice, you work on a little cuff strength. You're not solving any of his problems, right? If they come to you for training, what do? Well, all right, you're a little weak. No, this is what we have to train. The concept is reverse posturing. And that's kind of how I think of everything now. So what do I got to do to reverse this guy? So I'll start from the top to the bottom. And that's how I build kind of my programs for both rehab and training, is a reverse posturing. So what do I do? How do I fix his neck? I have to reverse him out of what he's in all day. Okay? And I know trust me, I'm not a big fan of, posture retraining, especially in the PT world. Come see me twice a week until your insurance has you stop coming in 3 weeks and we'll fix your posture. I mean, not very realistic. But what we can do is we can give them some guidance and give them some tools to work on these things themselves. Are you still going to sit at the computer like this? Yeah, maybe. But hopefully then you'll have a way of resetting some of that with some reverse posturing at some time. So it's working backwards. How do we fix his neck? How do we fix his scapula? How do we fix his glenohumeral joint? How do we fix his thoracic spine, lumbar spine? It's getting in the reverse of this, right? So easy example, thoracic spine. What does this guy need? Extension, absolutely, right? That's how we should train him. So that's functional stability training for him, okay? Now what's worse for us that work in the sport profession, some people that actually deal with athletes, is your athlete's doing this. This is like, right, this looks like T.O. tweeting right now maybe, right? He's coming up with some, or Cinco Ocho, I don't know, Cinco Ocho. At his computer sitting there all day, right? We'll have that on top of his athletic demands, and we got a pretty big recipe for him to set up for some issues. So, well, now let's shift gears. Let's talk about just dynamic stability now, because this is going to be how we enhance functional stability training. It's by enhancing dynamic stability. Dynamic stability is not just one thing, and it's really not just 4 things, but for the sake of this weekend, we'll talk about these 4 concepts and how they work into dynamic stability. But in no particular order: dynamic ligament tension, joint compression, force couples, and neuromuscular control. We're going to talk about each of those. So I think my notes are pretty good that you guys don't have to go crazy taking notes, writing stuff down, but these are going to be like the 4 domains we'll talk about. And really, you need all 4. So they're all equally as important, and they all feed into dynamic stability. If one of them is poor, you're going to have issues with dynamic stability. You can't make up with it with one of the other ones. You need all 4, kind of in broad terms. So the first one we'll talk about is joint compression, which is interesting because it's almost like a blend of static and dynamic stability. But joint compression is the first component of dynamic stability for us. That's basically not just having your joints, your knee, your shoulder, your hips, whatever it be, just sitting there, but having compression center that joint a little bit and then kind of find its way back into a stable position. So a common thing that we talk about here is the closed kinetic chain position, right? Closed chain, weight bearing type thing. So for the shoulder, well, for the knee it's obvious, right? You stand up. But for the shoulder, it's getting that closed chain or weight bearing position, right? That's going to provide dynamic stability because it's going to allow your muscles to be aligned in better orientation, so balance between their muscles. The second component of joint compression is muscle co-contraction. And that's going to be a big, big, big thing that we're going to actually train today and we're going to do in the afternoon during lab that we're not even realizing. But muscle co-contraction, so your muscle's ability to stabilize the joint by contracting the muscles all the way around it. Okay, and what that does is that pulls it in. So again, using your shoulder as a model, when I fire all my cuff, what happens? It comes back into the joint, right? It stabilizes it within the center of the joint. So muscle co-contraction creates joint compression. That's more important for us. Closed kinetic chain is not what we're looking for. That's static stability, not dynamic stability. That's you being in a weight-bearing position and then you being more stable. But that's not dynamic. Dynamic is when your muscles co-contract and then it compresses your joint and stays together. Okay, so that's joint compression. That's one thing we're going to work on. Let's say somebody has a shoulder injury. They dislocated their shoulder. They have reflexive inhibition of their rotator cuff. They're going to have a really hard time with dynamic stability because of that injury, right? So we can use weight bearing and closed kinetic chain to provide some of this joint compression so that way the muscles can do a little bit less work and still achieve dynamic stability. That's how we use closed chain in our thought process. But it's really about muscle co-contraction. That's the important thing. So again, the upper extremity is pretty easy model to understand because we talk about how closed chain and weight-bearing positions really help enhance alignment and then stabilization. But it's not just the shoulder. Interesting study done on the patellofemoral joint. If you look at displacing your patella lateral, okay, so kind of like subluxing or dislocating, whatever, more subluxing your patella. If you do not contract your quad, you can slide your kneecap a little bit easier than if you do contract your quad. So what this graph shows basically is when you contract your quad in red here, it takes more force to displace your patella. Okay, so it's not just the shoulder, but another interesting model we can see here is the patellofemoral joint. Contracting your quad creates more stability. Why? One, it's dynamic. Two, it compresses the joint, so it centers your patellofemoral joint a little bit, right? And then it gives your static stabilizers a little bit more control, a little bit more ability to function. So that's just the patellofemoral joint. The next component of dynamic stability after joint compression is dynamic ligament tension. Now, when we first started talking about this about give or take 20 years ago, and it was actually a pretty good study in Kane, I guess that's been longer than 20 years now, but when we first started talking about this, it was how the muscles blend with the capsule. It wasn't really how they blend with the fascia, but we're smarter now, right? We know that the fascia is involved. But how your muscles blend with your static stabilizers. So we call this dynamic ligament tension. When you contract your rotator cuff blends into the fascia and the capsule of your glenohumeral joint. So when you contract your rotator cuff, your capsule contracts. It pulls on those fibers as well. So that's called dynamic ligament tension. Okay, so your muscles can actually stabilize the joint as well. But it's not just that simple. It's not just a muscle contracting and stabilizing, dynamic stability-wise, but it's how it affects the capsule. So dynamic ligament tension. That's interesting. Again, going through examples. The patellofemoral joint is the no-brainer example here. All your retinacular tissue, all your patellofemoral ligaments and capsular tissue around your knee joint, it all blends in with all your muscles, your quads, your hamstrings, your groins, everything, they all blend together. You contract your quad and the whole thing tightens. Your retinacular tissue, your capsular tissue, it all tightens. Same thing as the shoulder. When we look at the shoulder, this is a cadaver dissection I did a few years ago, but kind of digging in deep into the shoulder in here. Look at all this tissue in here. The red's the muscle, obviously, right? This yellow that's not the muscle. This is a lot of fascial tissue. And you see how they all blend together, right? This is not fascial tissue, but that's fine. A little overweight. That's a flabby arm, I guess. But muscle tissue blending together and blending into the fibers of the capsule and the fascia, everything that connects it in between. That's dynamic ligament tension, the muscle contracting and stabilizing that joint. How does it work on the back? We all work together, right? The lumbar, thoracic, kind of whole area of fascial tissue that blend in the back of your spine. They all contract together when the lat contracts, when your paraspinals contract, when your lower trap, your mid trap, your upper trap contract, when your glutes contract. When all your muscles fire in this chain, it stabilizes all these joints because it stabilizes the fascial tissue and your capsular tissue. So dynamic ligament tension. So another important concept here, when we talk about just working one aspect of the body, maybe the posterior shoulder, maybe we need to think a little bit more deeper along the fascial lines and the way the muscles connect, but we'll talk about that a little bit more. The next concept for dynamic stability involves force couples. And what I'm going to try to do is not talk about force couples the way we were taught in school, like in a pure, just rudimentary kind of scientific nature of it, but more how a force couple is more functional, right? Maybe how that works to stabilize the body, because that's what we're talking about. That's what we want to do here. So with force couples, we're talking about the way muscles work together to move and position a joint. And when really that's the purpose of movement. That's the purpose of us, is aligning your body so that way you can perform, right? Can I, let's say, do a sport activity? Can I do a tennis serve in this posture? Absolutely. I'll do it like this. It'll probably stink, especially with my height restrictions. I don't know if I can get it over the net, but if I'm more upward and I get in this position, I'm more free to move, right? So I can do more. So it's about aligning yourself up in an optimal position to succeed and to minimize your chance of injury. So that's a little bit about the force couples. Let's break it down into agonistic and antagonistic force couples, just to talk about that briefly. When we talk about agonistic, so the muscles working together. So two muscles on the same team trying to achieve the same goal. It's not always as simple as, say, the hamstrings with your biceps and your semis. Maybe that's an easy one. They work together to position your knee, your hip, etc., right? It's not always just how your infraspinatus and your teres minor work together. Those are the no-brainers. It's more of the dynamic, how do multiple muscles around the body work together. And the scapula is a great model, I think, for how this force couple of agonistic muscles. So what's the goal of the upper trap, lower trap, and serratus anterior? To work together to elevate the arm, to swing that scapula up so that way you don't impinge when you raise your arm. Okay? Now what's the role that we learned the upper trap did in school? Right? Shrug, kind of. What's the lower trap? Down to press, right? So those muscles do two different things, right? But we're calling them agonistic force couples right now, meaning they work together to elevate the arm. That's an important concept. So the shoulder, the scapula is a good model. For hip extension, we talk about like the glutes, the hamstrings. You know, your hip extensors working together to extend your hip agonistically. Okay, so again, what are we doing? Somebody has an issue with your glutes, right? Maybe they're overactive with their hamstrings to make up for that deficit in glutes. So what do we do on our end? We need to get their glutes up so the hamstrings take a little bit less of the load, right? That's understanding an agonistic force couple. What about just trunk rotation? Well, the obliques, both sides. There's a bunch of muscles that do this, but just using two as an example. Both your external and internal obliques on both sides contract when you rotate, right? When I contract to the left, I'm getting both sides of my trunk to contract, to rotate to the left. It's not just these guys pulling me over, but it's on both sides. So those are, again, agonistic force couples. They don't do the same thing, but they work together. We need to understand those components, and that's what we'll talk about in our exercise progressions, so that way we can help get our patients, our clients, through these progressions and make sure they're not compensating. That's a big thing we're going to look at today, is how people perform a dead bug, or how about how people perform bird dog, for example. Do they extend their back? Do they extend their hip? What do they do? They're going to do it because they're going to compensate. They're going to figure it out, but how do they do it? The second concept for force couples on how it provides dynamic stability is when we talk about the antagonistic force couples. So this is a little different now. You have two muscles that do completely the opposite effect, yet somehow work together to provide dynamic stability. That's dynamic stability. The cuff, again, we'll talk about the shoulder. Your subscap, your internal rotator, and your posterior cuff, your infraspinatus and your teres minor. Subscap comes in, posterior cuff goes out. Right? You can't have two opposite, anything more opposite than that, right? But when they fire together, they both work on achieving dynamic stability, right? They both work on centering that humeral head. So that's two muscles doing the exact opposite thing to get one common goal. What happens if your subscap is a bunch stronger than your infraspinatus? What happens? You're not centered in the joint anymore, right? You're going to get pulled in one direction. That's going to be a muscle imbalance that causes problems down the road. Okay? What about your rectus, kind of your anterior core and your posterior core, your paraspinals? Same concept. Two sides of your trunk, one flexes, one extends, but when they contract together, they provide stability. Same concept for the core. Okay? So it's about, when we talk about these force couples, it's about thinking of the kinetic chain. And again, not to keep kind of talking down about our college educations, but this is how the kinetic chain was described to me, right? It's a chain, right? I mean, the word chain's in kinetic chain. So here's a picture of a chain. Well, there's some problems with that, with how it applies to us using it functionally, right? One is not every component of the kinetic chain is equally as important. And we'll get to that. Every joint's a little bit different. Maybe you have an injury of the hip or you have an injury of your toe. It's going to do different things to different parts of your bodies. It's not an equal distribution of the links in your chain. Our links are different. So I actually don't use a chain in my thought process. I use more of a ripple effect. So I call this the kinetic chain ripple effect, but what it is now is it's a centered kind of issue and then a kinetic chain ripple. So it's not that you have one link in the chain and the whole chain's done. It's about how does it affect it proximal to distal. So kinetic chain ripple kind of concept. So how do we use this? Let's say you have a problem with your hip. Let's say your hip's tight. We won't even say it's pain. Your hip's tight. What's going to happen? Well, your hip's tight here. Is it going to affect your other joints? Absolutely. But do you think it's going to affect his thoracic spine more than his left toe or his right toe? Sure. And that's one thing I see sometimes we get a little too carried away with sometimes. The whole, I stubbed my toe and now I have shoulder impingement. Okay. I mean, maybe. I mean, Stub your toe, now I'm pronating, I'm externally rotated, my hips externally rotated, that's changing the tilt of my pelvis, and then my thoracic spine's different, and then my scapula is angled different, and then, okay, yeah, you're impinging, but okay, does that work? Yes, absolutely. I'm not saying that's not right, but there's gotta be more things going on, right? Let's go back to that picture of that guy sitting at the desk. That's way more important than you stubbing your toe or why you have shoulder impingement. So just an interesting concept. It's more centered around your source. So if your hip's your source, your lumbar spine and your knee are going to have issues, right? That's why patellofemoral pain now, we treat the hip to fix your patellofemoral pain. For lumbar disorders, low back pain, we treat the hip, right? Are you working on his toes? Yeah, I mean, if you got time, I mean, great. I mean, that's good. Does he need it? Yeah. But focus on what's centered around your problem. That's one thing just in terms of the kinetic chain, that sometimes I see people get too carried away, and that's great. But if you've got X amount of minutes with your client, your patient, whatever it is, make sure you're not doing too vague of a program and center in on what's the important aspects. The other thing I think that's kind of misleading about the kinetic chain is that this is joints. The kinetic chain is a bunch of joints and how they feed into one another, right? So it doesn't take into effect the force couples we talked about. It doesn't take into effect postural deficits, muscle imbalances, fascial connections, poor movement, all that stuff put together. What it doesn't take into effect is what joins the links. So the traditional kinetic chain thought process with joints should kind of be expanded a little bit. We have to think about how the fascia between each joint and the muscle tissue between each joint kind of plays together. So again, just looking at a picture from anatomy trains, Tom Meyer's concepts of fascial integration that obviously, a bunch of people are in line with nowadays. But if you look at this whole concept, if somebody has, a shoulder problem, we need to treat way more than just the posterior shoulder, right? We need to train his rhomboids, his mid-trap, his upper trap, his levator, his low trap in certain ways. We have to work those together. So it's understanding the kinetic chain in that manner, how things link together through fascial and muscle integration. But two is how they function together. To me, this is still kinetic chain. And this is something we have to be careful about right here. So this is Yanda's upper body cross syndrome. But what we have here, if you look at a typical posture, so we have tightness in the upper traps, the levators, tighten your pecs, right? You see this, everybody in this room, right? What do we have? We have inhibited or weak deep neck flexors and then your low trap and serratus. This creates impingement, okay? You can spend all day working on lower trap strength, but that person's going to impinge because everything else is still deficient. Okay, so that's the other concept of the kinetic chain. It's not just what links together, but what works together. So, okay, you have posterior shoulder impingement, maybe something right here. You have to look at the pecs. You have to look at his neck. You have to look at his upper neck. You have to look at his scapulothoracic joint. That's the true links that we need to talk about in terms of force couples. So I've been guilty of this. When I first came into practice, it was, okay, this guy's lower trap, purely biomechanical, which was, I pride myself in having that background of, biomechanics and how things work. Purely biomechanical, he is not posteriorly tilting his scapula. So I want to work on his lower trap and serrator and stuff. I want to work on those muscle groups. And you can work on it, work on it, work on it. You get the muscle functioning, but he still can't posterior tilt because of everything else that's going on. You miss the boat on the whole kinetic chain concept, okay? So again, dynamic stability now for the lower trap and to stabilize the scapula, it's ineffective if you don't look at the mobility issues elsewhere as well. So just something again to think about. The last concept of dynamic stability we'll talk about now is about neuromuscular control. Okay, so neuromuscular control, fancy concept. It's basically how your brain and your muscles work together, right? Neuromuscular control. It's a combination of proprioception and kinesthesia. So proprioception, understanding where your joint is in space, and kinesthesia, understanding where your joint's moving in space and where your body's moving in space. And you put it all together. It's simply the efferent response to an afferent input, right? Or a motor response to a sensory input. So this could be as simple as something reflexive. You put your finger on a hot stove and jump right back. You don't even feel it yet because it goes through your spinal cord quickly in this quick little reflexive type motion. You don't even feel it, but you pull back. Reflex. That's neuromuscular control to an extent. It's your brain saying how to move your body. So that's you, whatever, running, and you start to feel your hamstring cramping, and your body says, hey, I need to use a little bit less of my hamstring. That's neuromuscular control too. That's just weird kind of ways to think about it. Maybe even visual, like, okay, a ball's coming flying at my face. I need to get out of the way, right? We don't train that. That's something that happens. That's neuromuscular control. That's a sensory input from your vision that comes into a motor output, a motor program that we do. We can train this. There's plasticity of your neurons and your brain tissue and everything that we can do, that plasticity of your neuromuscular system that we can train. So everybody says, we talk about rhythmic stabilizations, dynamic stabilization programs, all of our manual techniques. What's the efficacy that these work? It's very, very challenging to study that, to perform a research project that shows that there's some efficacy behind that. But what we do is we know that you can learn. You learn motor patterns. So the more we train correct motor patterns, the more that the body adapts and learns, and that becomes normal. Unfortunately for us, this is becoming normal because this is how we sit all day. So that's your motor control program that's kind of entered into your brain right now. We can train that. That's why you see a lot of times when you're working with your people, your clients, your patients, you see that initially in the first couple of weeks, maybe their strength or their symptoms or whatever, boom, get a ton better in the first couple of weeks. Strength's a good model. First couple of weeks you get stronger, but you don't look bigger. You don't have hypertrophy. What happened? Neuromuscular control. The way you responded to that motor input. So that's a little bit about what creates dynamic stability. Now, what influences dynamic stability? Because this is really going to be what we do to fix it, right? Or to enhance it. So what influences dynamic stability? There's a bunch of things influence dynamic stability. Weakness. So again, looking at Yanda's cross syndrome. If you have weakness in one particular area, that's going to cause an issue with dynamic stabilization because that muscle can't do its job as well as it wants to. Fatigue. That's probably even bigger. Your muscle maybe can stabilize, but then kind of shuts down over time because it's tired. It doesn't want to do its work. You know what? I'm going to just chill out and let your static stability take over right now. That's a problem. Muscle imbalances. Again, maybe one area is too strong, one area is too tight. Their agonistic and antagonistic force couples aren't aligned to work well together. And then obviously injury, swelling, surgery, all those things play together. If you just look at swelling, here's a good example. Every injury and every surgery is going to probably have swelling, right? This is the amount of fluid in your knee and the ability for your quad to kick out. So your quad peak torque with the amount of fluid. These are cc's in your knee. So with no swelling, you have about 200, we'll say, this is on this scale, I just know the numbers, about 200 of your quad peak torque that you can kick out with just 40 cc's of fluid in your knee. That's not a ton. I mean, if anybody has seen like a doc drain a knee or anything like that, I mean, you're pulling out 100 sometimes on a really bad acute bleed in somebody. You're pulling out a lot of fluid. 40 cc's, your ability for your quad to contract drops in half. That's just 40 cc's. It's not a ton of swelling. It's swelling, but it's not a ton. But you can see that goes down the whole time. That's swelling. Every injury, every surgery is going to produce swelling. So your quad can't contract. If your quad can't contract, it can't stabilize, right? These are important concepts for us. So on the rehab end for us, we can talk about functional exercises, et cetera, but if you don't do the basics first, decrease your inflammation, decrease your swelling, get rid of all your post-op trauma or post-injury trauma, then we're never going to be able to work on dynamic stability. So what is functional stability training then? It's working on all these. It's working on their strength. It's working on their endurance. It's working on their imbalances. It's working on reducing their swelling, et cetera. That's functional stability training. That's what we need to do to enhance dynamic stability. It's working on all these issues. We know those are problems. That's how we develop our programs around there. So again, what's the components that we'll talk about? Motor control training. Teaching the body how it's supposed to move again. Because unfortunately, because of our postural, how we're sitting right now, we move poorly. That's been a habitual thing that we've learned over time for whatever reason. Maybe you have a compensation, maybe you just have poor posture, maybe you have some muscle imbalances, but it's motor control training. So when we talk about the core, which is going to shift gears soon when we talk about the core, it's not just jumping into a nice, great exercise that we found on the internet. It's motor control first, or you're just going to do it with compensation. The second is isolated strengthening. And I'm big on this. I think just jumping into functional training and say, I'm a functional person, that's all I work on, because that's going to get my athletes better faster. That's going to get people feeling better. Yeah, I think that's great, but you need strength too. You can't tell me that just working on isolated external rotation isn't going to enhance dynamic stability. I'm 100% positive it is. And that's just working on strength, because it can function better, it's stronger, it can stabilize better, it can just work better. So isolated strengthening is important. So how do you get the cuff strong? Is it through dynamic stabilization? No. That's how you get the cuff smart. That's how you get your muscles smart to work better. You get it strong by exercises. And there's no better way to get the posterior cuff stronger than external rotation. There's no better way to get your quad stronger than knee extension. How many people have knee extension machines in their facility still? Yeah? That's good. See, I like it. There's certain people you can't do knee extension with for various reasons. Is it functional? No, not at all, right? But if their quad's weak, you got to do something to get the quad strength back up. Now again, when it comes to the reviews, don't say Mike's crazy. He's saying get a knee extension machine. I'm not. But I'm just saying we still need to work on isolated strengthening, or it's not going to work well when we get to dynamic stabilization. You need to be strong. You need to be functioning. Some of it's strength, and some of it is inhibition. We talked about the swelling. It's a good example. Sport. Somebody's running. Let's say they're running to second base. They slide head first. While they're sliding, they're midair. They're feeling great about themselves. I'm going to be safe. My shoulder's strong. I feel good. Bam, they dislocate their shoulder. Is their muscle weak? Was it weak 2 seconds ago? No, it was great, right? Is it weak now? Well, on your test it is, right? Because it's inhibited. So there's a difference between strengthening and just working on inhibition. It's inhibited from pain, swelling, inflammation, whatever it may be. So a concept to think about for strengthening. Endurance training, another important concept, especially when we talk about functional stability training and control of your body. It's about endurance. Right now, we're all feeling pretty good, not bad. By the time Eric's up here giving his talks in a little bit, we're all going to be a little bit more lower, right? We're going to be a little bit more sagging because we're getting tired. We're getting tired of sitting in one position. Okay? So that's endurance training. Then again, the reverse posturing. That's how I kind of, for you guys, that's how I almost want you to think about going back tomorrow when you get to in front of your clients and your patients. Take a step back and think about reconstructing him, right? Like what do companies do right now? Like Keurig, great example. This is completely off topic, by the way, which I tend to do. Keurig's a great example, right? Great coffee machine. We were just talking about this the other day. Great coffee machine, right? Their patent's expiring on those K-Cups, right? So what are all those other companies going to do? Reverse engineer it and make it cheaper. Okay, now I don't want you guys to make it cheaper, provide an inferior concept, but I want you to reverse engineer all the people you see tomorrow, okay? Not just, okay, this person, I want to train them, I'm going to put them on this program because this is the program I built. I think this is a real effective program. Your program should reverse train everybody so that way they're kind of redoing that concept. So, and then obviously how it goes together with dynamic stability and neuromuscular control. So what's the conclusion of all this? What's functional stability training? Train the body to perform coordinated functional movements without compensation. That's it. Right now, all of us in this room could have terrible glutes. We probably all kind of do anyway. You're still going to be able to extend your hip. You're still going to be able to externally rotate your hip. Why? Because we'll figure it out. We're humans, man. That's what we've done. We figured out how to compensate. Okay? That's one of the first things I learned about athletes. You know why an athlete is good? It's probably, I'm way oversimplifying this. They can compensate better than us. They can figure out a better way to use their body to achieve what they want to achieve. It might not be optimal, and it might break down, it might kind of hurt them over time, but that's what athletes can do. They have better motor control, better neuromuscular control that they can figure it out. Their glutes aren't working. Okay, no problem. I'll figure this out. I'm still going to be able to run. I'm still going to hit a home run. I'm still going to, return this touchdown. Okay? So that's just the concept here, is performing it without compensation. When we get to the lab today, we're going to do some basic core stuff, and you're all going to do it poorly. I'll be willing to bet that 80% of you guys do it perfectly. And this is good. I've challenged you. So now during lunch, you guys are all going to be like getting ready, putting some E-stim on your abs maybe, trying to get the six-pack abs thing going. It's about compensation and us making sure we're not compensating. So we'll get to that when we talk about the core, but that's just a brief intro into what we're going to talk about in terms of principles of why we're going to pick the exercise we're going to do. I'm going to probably surprise you with the simplicity of what we're going to talk about today. Dead bugs, bird dogs, planks, boring, right? Your patients and your clients think they're boring too, right? That's my biggest struggle. I work with a lot of baseball players. I work with a lot of pitchers. What do I make them do for a good chunk of their day? Rotator cuff exercises. How boring is that? They don't look better. They don't feel better. They will. You know, they're not stronger. They're not bigger, right? But they're just doing these mundane exercises just all day long, right? We're training them to do these. That's what functional stability training is, unfortunately. It's boring. So if you want to jump right into the coolest new exercise that you see on somebody's YouTube page, this isn't for you. This is about treating people and training them how to move correctly, and you'll reap the rewards. Everyone's going to feel better, everyone's going to perform better, and you're going to get better rehab gains and better training gains. But it's going to be a hard sell. So that's your guys' skill set here. You have to sell why you're doing these basic exercises. Hey, if I'm not getting a ripped six-pack, why am I doing this, right? That's your guys' job. So I think we're making a transition in our professions from looking good and stuff to feeling good. And that's really what we're slanting for. So